Hello, this is Dr. Jack Krasuski with the ethics lecture for your USMLE exam. And let's begin. This is a single module lecture, and we begin a review of the ethical principles. So beneficence, right? Healing is the goal of medicine. Our job is to relieve suffering and to cure illness if possible, and if not, then to manage the sequelae, the symptoms, and the disability that is associated with it to try to minimize those. The next ethical principle is non-malfeasance. Now, non-malfeasance is doing no harm. Now, sometimes this is actually written as non-maleficence, right? It could go either way, but non-maleficence is really do no evil. And most physicians are not setting out to do evil, right? I mean, sure, there are psychopaths in every profession. So it's not so much first do no evil, it really is first do no harm. Most harms occur through negligence, oversights, sloppiness, but not because someone has evil intention. So non-malfeasance is a more appropriate term than non-maleficence. And in this one, we always need to weigh the risks and benefits, because few of our interventions are 100% beneficial. Almost all interventions that do provide benefit have some risk involved. And this ratio of benefits to risks differs by circumstance and by the patient and where that patient is in their lives and the stage of their illness too, and severity of it. Autonomy is our next ethical principle. Patients have a right to self-determine, to control, and to make their own choices, to make decisions. So if the criteria for informed consent have been met, patients may make decisions that we as physicians disagree with. We may have chosen very differently, but if that person has really gone through the informed consent procedure and has the capacity to make that decision, understands it, and is not being coerced, they have the right to make decisions we may disagree with. In some situations, however, autonomy may be limited or abrogated in the interest of preserving the dignity of that person. The dignity of that person is another ethical principle that we wish to hew to. So, for example, I'm a psychiatrist, and I've had to, on many occasions, involuntarily commit or hospitalize patients when they are at a high risk of hurting themselves through attempting suicide, are at high risk of harming someone else, or have perhaps such a florid, severe type of psychosis or mood disorder that they are unable to take care of basic needs, or have such impaired judgment that they may run in front of a truck on the highway or something like that because they don't understand. Next is truthfulness, sometimes also presented as truth-telling. That really means the same thing. This is a physician's duty to share relevant information without omitting relevant information. So physicians must not lie to cover mistakes or omit important diagnostic or prognostic information that would be relevant to understanding what situation is being presented, such as, some medical oversight. Next is dignity. It's a recognized element of personhood that allows the individual to make decisions that they deem best for themselves. Sometimes this is termed respect for the person. Physicians ought to seek to maintain the dignity of the person whenever possible. And now dignity links to autonomy and to decision-making. And then our next ethical principle is justice. Everyone has a right to fair allocation of resources. Now this comes up frequently with transplant organs. Just recently it was coming up with the COVID-19 vaccines because they were limited. Who should get them first? Who should wait in line longer? So that those decisions that were being made were hopefully based on the principle of justice. And also emergency care. We have decided as a society that everyone deserves to have emergency care, Perhaps we have not yet decided whether everyone should just have care in general, medical care in general, but at least emergency care. We do. Next is the principle of fidelity. It's the physician's duty to place the patient's welfare above all else. The patient is not there to meet the doctor's needs. Other than the physician can expect payment for his or her services, but not meet any of our other kind of needs. And you'll see there will be some questions even in what I present here that is based on that principle. And then a fiduciary relationship. This isn't a principle, but it's the type of a relationship that we have between us as a clinician or physician and the patient. So the physician is a trustee of the patient's health, and we have both a legal and ethical responsibility to guard it. Now let's review several questions. A couple with their 3-year-old child requests that you test that son for Huntington's disease because the father has just been diagnosed with the disease. You refuse, despite the parent's angry response, and base your refusal on which ethical principle? Autonomy, beneficence, non-malfeasance, justice, or truthfulness? And the right answer is non-malfeasance. Now, why? Well, first of all, this is a 3-year-old child. This is not, that child is not himself giving informed consent. They're a minor. They're not in a position to understand the ramifications. So his parents or parents or guardians are providing informed consent for that child. Now, because this question relates to Huntington's disease, which very importantly right now has no curative treatments available to it. There are symptomatic treatments when someone develops symptoms of it, but that is very different than providing a treatment that would prevent the onset of the illness or cure it in some way, or arrest its progression. Now, if there was such a treatment, then indeed we would want to test all kids. We would want to test anybody before they developed the disease, anyone who was at risk of it because of primarily a family history. But because this is a child and because there is no curative treatment, the chance of causing more harm than good is so high that all societies, neurological societies, Huntington's disease associations recommend against testing minors who are asymptomatic, I should say, because there are forms of Huntington disease that start in youth. Our next question, a 26-year-old man requests that you test him for Huntington's disease because his father has just been diagnosed with the disease. Which principle will guide your decision on whether to grant his request? Autonomy, beneficence, non-malfeasance, justice, or truthfulness? So similar question with identical response options, and this time the answer is autonomy. So this is a 26-year-old man, and as an adult, as long as he was able to go through the informed consent procedure, he has the control, the self-determination, the self-governance to choose whether or not to have himself tested. A physician has a patient clean his office as part of her vocational rehabilitation, but does not compensate her. The physician's actions would be considered unethical due to breaching of which type of relationship that he has with the patient. A non-maleficent relationship, a fiduciary one, an unequal one, a professional one, or a time-limited relationship. And here, hopefully it's clear, it's a fiduciary relationship, right? Next question, a 65-year-old woman diagnosed with primary progressive multiple sclerosis refuses ventilatory support. She dies in the following months. On autopsy, she is found to have been misdiagnosed. When deciding what to tell her husband, which ethical principle would be prominent in the physician's considerations? autonomy, beneficence, non-malfeasance, justice, or truthfulness, and it would be truthfulness. Hopefully that was pretty easy. Now, let me present one slide and then we'll do one more question. So, medication double effect. So, oftentimes ethical obligations can clash, right? We have, as physicians, an obligation to relieve suffering, but also to do no harm. So, perhaps those two can clash, right? That relieving suffering may lead to some harm, or by not doing harm, that may increase suffering. So when these ethical obligations clash based on the ethical principles, we need to involve the patient, the family, anyone who's the designated decision maker, and have a sensitive discussion and enough time for everyone involved to decide among the options which can be provided and the pros and cons of each. So we really want to do kind of an extended informed consent procedure with everyone involved, including, if there are, and there often are, many members of the medical team, primary care provider, the different specialists, surgeons, oncologists, for example, pain medicine specialists, and so forth. So the double effect, this is really like a medication double effect for the most part. But more generally, it's when a treatment, commonly a medication, is given to alleviate pain or some other form of suffering, and that it may also lead to unintended consequences, such as, for example, shortening a patient's life. So in pursuing the principle of beneficence, right, the alleviation of pain and suffering, an unintended, it's foreseeable, right, unintended, but it is foreseeable consequence arises secondarily, and that is that death may come sooner than without the medication. So by providing an opioid analgesic, we may actually hasten death as we are pursuing the alleviation of the patient's pain. Clinicians should not hesitate to provide an effective dose of a medication, however, to control that pain. And this is a common dilemma, this double effect in palliative care, because many of those palliative treatments can indeed hasten death. So that was our review. So now let's look at how this question could be asked on your exam. A 27-year-old man has advanced osteosarcoma. His cancer has spread into his pelvis and spinal canal. He has concurrent sepsis and pneumonia and has difficulty breathing. His opioid dosage is increased to match his pain. However, he starts to show signs of hyperventilation. He asks for an increase in his opioid dose so that he can cope with the pain. The risks and benefits are explained by the physician, and the patient wants to proceed with the dose increase. He then dies within 24 hours. The outcome of this case is best characterized as which of the following: double effect, a facilitated suicide, an unintentional suicide, physician malfeasance, or medical malpractice. And the best answer here is going to be the double effect, right? Because this is not a suicide. The goal was not to end the patient's life. That was an unintended, even if foreseeable consequence. The main motivation was beneficent to relieve his pain. So it's hard to argue that the physician is engaged in any kind of unwarranted causing of harm. Harm did occur, the hastening of death, but that was a secondary and unintended, even if foreseeable consequence of doing good, right? And this would, a case like this would be, anyone would be hard-pressed to see it as medical malpractice. All right, so that's a quick review. Now, some of these issues we will pick up in another lecture, the elder and end-of-life issues. So see you back soon for the next lecture. Signing off, it's Dr. Jack. Thank you.